Olá, eu converso com o Dr. Patrick Ott, que é oncologista clínico do Dana-Farber, sobre sequenciamento no melanoma. Dr. Patrick, how to sequence the different treatments for metastatic melanoma? You had that on your presentation today.
Yes. So I was tasked to look into our experience and data that could guide us when particularly in patients with metastatic melanoma who have a BRAF V600 mutation, where the question always comes up, should they receive the immunotherapy first or the targeted therapy first? And sort of the consensus in the community certainly is that it should be immunotherapy unless there is high tumor burden, unless there's rapid progression, or there's maybe really a specific reason not to give immunotherapy, for example, autoimmune disease that's pre-existent. There are some, what I discussed is that there are some data sets that are supportive of this notion. For example, there's patients who receive target therapies, and then when they progress, they are basically progressing so quickly that they can never receive the immunotherapy. Those data are unfortunately a little bit old, and they were done at a time where only vemurafenib was available on the target therapy side and only ipilimumab on the immunotherapy side. So it may be a little bit different now that we have PD-1 and ipilimumab that work quicker. So what I mean by that is like if a patient fails the target therapies, so those immunotherapies may kick in quicker, but nevertheless, there's probably patients who receive targeted therapy and then never even get the immunotherapy. So that's certainly concerning, that to me like a pretty compelling argument to start with immunotherapy. On the other side, there's data that patients who have low disease volume, low number of disease sites, and normal LDH, that they actually have good long-term outcome even with the target therapy. So that would be one reason to use the target therapy first, or at least not deprioritize it based on the data. I had also talked about neoadjuvant therapy in a different talk, and there's data from that literature that patients who have received immunotherapy have particularly have responses to immunotherapy, have remarkably good outcome, and that data in conjunction with the high response rate with ipilimumab and nivolumab, particularly in patients who have BRAF mutant melanoma, and I went through phase 3 trial data sets and landmark PFS data, looking at 1, 2, 3 year data across the board. Immunotherapy seems to certainly not be inferior to target therapy in terms of those long-term outcome evaluations. And so overall, my conclusion was, like, looking at all these data, that it's probably still very reasonable to actually use immunotherapy first. And then I had like another area of research where the target therapies and the PD-1 inhibitors are used in combination, particularly just the PD-1, not the ipilimumab. I discussed data from phase 1 and 2 studies that shows sort of initial good responses, but there's not yet compelling evidence that this triple, or there's not enough evidence, because the phase 3 data are not out yet to actually use that in clinical practice, but it may become a new standard, so that I could see that maybe in a year or two from now, a patient that has a BRAF mutant melanoma, that an additional choice may be to actually start with what's called a triple regimen.
Ok, thank you so much. Esta é a cobertura do 7º Simpósio Internacional Oncoclínicas. Continuem acessando, que teremos mais vídeos a respeito das apresentações deste grandioso encontro.